Good morning. My name is Patrice Sabecki, and I am honored to be the first to welcome you to our day-long conference of Rethinking Critical Care, Reducing the Incidence of Delirium. My part of today's presentation is on the understanding of the differences between dementia, delirium, and depression, which will aid in our assessments and improve our patient outcomes. Learning objectives today are to be able to define and differentiate between the diseases of dementia, delirium, and depression, to describe the risk factors associated with these diseases, and to be able to compare and contrast the symptoms of dementia, delirium, and depression. Dementia isn't a specific disease. Instead, it describes a group of symptoms affecting thinking and social abilities, which affect severely enough the patient to interfere with their daily functioning. 10 important facts to understand about dementia. The first is that dementia mainly affects older people, but it is not a normal part of aging. It is a syndrome, usually of a chronic or progressive nature, caused by a variety of brain illnesses that affect memory, thinking, behavior, and ability to perform everyday activities. The total number of people with dementia worldwide in 2010 was estimated to be 35.6 million. Among them, 58% live in low and middle income countries, and this proportion is projected to rise to 71% by the year 2050. The total number of new cases of dementia each year worldwide is nearly 7.7 million, which converts to nearly one new case every 4 seconds. The number of people with dementia is expected to nearly double every 20 years to 65.7 million in the year 2030 and a staggering 115.4 million by the year 2050. The high cost of this disease will challenge healthcare systems to deal with the predicted future increase of cases. The costs are estimated at $604 billion per year at the present and are set to increase even more quickly than the prevalence. Caring for dementia patients is overwhelming, not only for the healthcare professionals, but for the caregivers. The stresses include physical, emotional, and economic pressures. Caregivers require support from the health, social, financial, and legal systems. The principal goals for dementia care are diagnosing cases early, optimizing physical health, cognition, activity, and well-being, detecting and treating behavioral and psychological symptoms, and providing information and long-term support to caregivers. People with dementia are frequently denied the basic rights and freedoms available to others. For example, physical and chemical restraints are used extensively in aged care facilities as well as acute care settings. Improving the awareness and understanding of dementia across all levels of society is needed in order to decrease this discrimination and to improve the quality of life for the people with dementia and their caregivers. More research is needed in order to do this. It is needed to develop new and more effective treatments and to better understand the causes of dementia, as well as to identify the modifiable risk factors of dementia. At this time, research on the subject is still very scarce. To address this important health priority, there are actions that can be taken. We need to promote a dementia-friendly society, make dementia a public health and social care priority everywhere, improve attitudes to and understanding of dementia, and to invest in health and social systems which improve care and services for people with dementia and their caregivers, and lastly, to increase research on dementia. And this is where we all come in. So there are many types of dementia. Some of them that I'm going to talk to belong to the first group, degenerative neurological diseases. This is the bulk of types of dementia and includes Alzheimer's, dementia with Lewy bodies, frontal temporal lobar degenerations, Parkinson's, and Huntington's. There are also infections that affect the central nervous system, including HIV dementia complex and Creutzfeldt-Jakob disease, those that are associated with chronic drug use, those that are associated with hydrocephalus, and those associated with depression. There are many risk factors for dementia, some that can be changed and some that cannot. Of the ones that can be changed, the first is age. As you know, the risk of Alzheimer's disease, vascular dementia, and several other dementias greatly increases, especially after the age of 65. However, dementia isn't a normal part of aging, and dementia can occur in younger people. Next is family history. If you have a family history of dementia, you're at greater risk of developing the condition. However, many people with a family history never develop symptoms, and many people without a family history do. If you have a specific gene mutation, you're at a significantly greater risk of developing certain types of dementia. Tests exist to determine if genetic mutations are present, although physicians are reluctant to order them due to inaccurate findings. And for people with Down syndrome, by middle age, many of them are developing plaques and tangles in the brain that are associated with Alzheimer's disease, and some may then lead to dementia. Now moving on to risk factors that can be changed, and most can be changed in a fairly easy way. Most have to do with lifestyle changes such as diet, exercise, or elimination of unhealthy behaviors, such as alcohol abuse, smoking, eating fat-laden or processed diets, which lead to atherosclerosis and cholesterol, also leading to obesity, all which increase the risk of dementia. We need to modify these lifestyles so that we can maintain a healthy blood pressure, because both high and low blood pressure are risk factors for dementia. Dementia, especially in middle-aged men, may be an indication for the development of dementia. So again, exercise is one lifestyle change that may not decrease it, or may not totally eradicate it, but can help to decrease depression. Women taking estrogen and progesterone years after menopause are at greater risk for developing dementia, as well as elevated blood levels of homocysteine may increase your risk. Again, we talked about being overweight and the risk of smoking. Let's take a look at this video on Alzheimer's.
The human brain is a remarkable organ. Complex chemical and electrical processes take place within our brains that let us speak, move, see, remember, feel emotions, and make decisions. Inside our normal healthy brain, millions of cells and neurons that communicate with one another and receive messages from each other as electrical charges travel down the axon to begin to the neuron. The electrical charges release chemical messengers called neurotransmitters. The transmitters move across microscopic gaps or synapses between neurons. They bind to receptor sites on the dendrites and the next neuron. This cellular circuitry enables communication within the brain. Healthy neurotransmission is important for the brain to function well. Alzheimer's disease disrupts this intricate interplay. By compromising the ability of neurons to communicate with one another, the disease over time destroys memory and thinking skills. Scientific research has revealed some of the brain changes that take place in Alzheimer's disease. Abnormal structures called beta-amyloid plaques and neurofibrillary tangles are classic biological hallmarks of the disease.
Again, let's talk about some of the risk factors that are associated with Alzheimer's disease. It is not part of the normal aging, but your risk greatly increases after you reach age 65. Nearly half of those older patients aged 85 and over have Alzheimer's. Your risk of developing Alzheimer's appears to be somewhat higher if a first-degree relative, such as your parent, brother, or sister, has the disease. Scientists have identified rare changes, mutations, in 3 genes that virtually guarantee a person who inherits them will develop Alzheimer's. But these mutations account for less than 5% of Alzheimer's disease. Most genetic mechanisms of Alzheimer's among families remain largely unexplained. Other risk genes have been identified but not conclusively confirmed. Women are more likely than men to develop Alzheimer's disease, in part because they live longer. People with mild cognitive impairment have memory problems or other symptoms of cognitive decline that are worse than might be expected for their age, but they are not severe enough to be diagnosed as dementia. Those with MCI have an increased risk, but not a certainty of later developing dementia. Taking action to develop a healthy lifestyle and strategies to compensate for memory loss at this stage may help delay or prevent the progression of dementia. As well, people who have a severe head trauma or repeated head trauma appear to have an increased incidence of Alzheimer's disease. Here's some facts, again, to think about as relationship to Alzheimer's disease. 5.2 million Americans of all ages have Alzheimer's disease in 2013. This includes an estimated 5 million people aged 65 and older, and approximately 200,000 individuals under the age of 65 who have younger onset Alzheimer's. In 2010, 83,494 Americans died of Alzheimer's disease. It is the 6th leading cause of death in the United States overall, and the 5th leading cause of death for those aged 65 and older. In 2013 also, the direct costs of caring for those with Alzheimer's to the American society totaled an estimated $203 billion, including $142 billion in costs to Medicare and Medicaid alone. Due to the physical and emotional toll of caregiving, Alzheimer's and dementia caregivers had an additional $9.1 billion in additional healthcare costs of their own in the year 2012. Let's move our focus a little bit from the long progressive dementias to the one of shorter duration. Delirium is a sudden change in mental status or sudden confusion, which develops over hours to days. Here's a nice video talking about the different types of delirium. I hope you'll enjoy it.
There is a condition that is difficult to detect, but it can be a medical emergency. It's called delirium, and there are 2 basic kinds, quiet and excited. They may look a lot like dementia, but they can be particularly hard to identify. If you are a caregiver, you need to know the signs of quiet or excited delirium and what to do about them. The first one we'll cover is quiet delirium. Here are some signs you should look for. Your loved one may not be thinking clearly or have trouble paying attention, not be aware of what's going on in the immediate surroundings, may seem out of touch, avoids making eye contact, might not know who you are or where they are, and may occasionally see or hear things that are not really there but seem real. These symptoms are different from your loved one's usual behaviors. Other symptoms can include slurred speech, answering very slowly, talking about things that don't make sense, and looking or appearing very sad. Let's see how this works with Frank and Elaine. What are you up to here? Why don't we shut this off until after we have lunch? The train should be pulling in soon. What train, Frank? I gotta get on the train. symptoms of excited delirium are more obvious than those of quiet delirium. They may include restlessness, attempts to get up and move around with no apparent purpose, aggressive or random behavior with various objects, and fearfulness. Like quiet delirium, however, they last longer than episodes of agitation and dementia. Other symptoms can include physical attacks on caregivers, such as punching and pinching, yelling, throwing objects, being disoriented, and not recognizing the caregiver. As with quiet delirium, your loved one will probably not be able to understand or explain why they are acting so differently. But you need to realize that the situation has changed radically. A person who is experiencing excited delirium needs professional medical care.
How you doing, honey? It's time for your pills. Brought your glass of water. He's out of control. He needs to see a doctor right away.
Let's move on to the risk factors of delirium. Dehydration, lack of thiamine and vitamin B12, malnutrition, alcohol or illegal drug overdose, urinary retention, usually due to a blockage of urinary passage, infections such as pneumonia or sepsis, lack of oxygen to tissue, hormonal issues such as hyper or hypothyroidism, lack of sleep, which we can probably all relate to, changes in environment, especially those like hospitalization or moving. And there's a whole list of drugs that can include risk factors for delirium. A lot of these we'll go into more in our next segment, but a few of them to mention are sedatives, anti-Parkinson's agent, analgesics, non-steroidal anti-inflammatory drugs, antihistamines, anti-nauseants, scopolamine, antibiotics, lithium, steroids, digitalis, antiarrhythmics, antihypertensives, and over-the-counter, type things such as Jimson weed and belladonna extract. The risk of developing delirium shows up more often in patients who are in the hospital. Again, it goes back to the risk factor of change. Delirium affects 10 to 30% of patients in the hospital who have an illness, and also more than 50% of people in high-risk populations, such as ICUs and CCUs, are affected by delirium. These numbers include people who have had surgery, as well as 25% of cancer patients, 30 to 40% of those with human immunodeficiency virus, or HIV, 60% of nursing home residents older than 75 years of age, 70% of intensive care patients, and 80% of patients at end-of-life care. Patients are at higher risk for developing delirium if they have more than one illness, take more than one type of medicine, have had an illness for a long time, have trouble hearing or seeing, have lack of sleep, have had a stroke, have Parkinson's disease, dementia, or chronic liver disease, abruptly stopped using alcohol or drugs, have burns, are on dialysis, are unable to move because of catheters or restraints, and are dehydrated. Some staggering statistics about delirium is that more than 7 million hospitalized Americans suffer from delirium each year. Among those hospitalized patients who survived their initial episode of delirium have rates of persistent delirium at discharge. At discharge, it's 45%. 1 month later, it's only down to 33%. 3 months later, down to 26%. And only down to 21% 6 months post-discharge. And that's usually with extensive occupational therapy, physical therapy, and care by loving family members. More than 60% of patients with delirium are not recognized by the healthcare system. And this is the importance of what we're doing today. Compared to hospitalized patients with no delirium, after adjusting for age, gender, race, and comorbidity, delirious patients have higher mortality rates at 1 month, 14% versus 5%, at 6 months, 22% versus 11%, and at 23 months, 38% still have a incidence of high mortality versus 28% for those without delirium. Those with delirium tend to have longer hospital stays, 21 days versus 9 days without delirium, a higher probability of receiving care in long-term care settings at discharge, and this includes having to move from their home into an institution. And that rate is 47% versus 18% for those without delirium at discharge. 6 months, still 43% versus 8%, and at 15 months, 33% versus 11%. They also have a higher probability of developing dementia at 48 months, 63% of those who suffered delirium versus 8% who did not. Lastly, we'll talk about depression. Depression is a medical illness that causes a persistent feeling of sadness and loss of interest, and may include physical symptoms. Some of the symptoms of delirium include irritability and frustration, even over small matters, feelings of sadness or unhappiness, loss of interest of pleasure in normal activities, reduced sex drive, insomnia or excessive sleeping, changes in appetite, agitation or restlessness, irritability or angry outbursts, slowed thinking, speaking, or body movements, indecisiveness, distractibility, and decreased concentration, fatigue, tiredness, and loss of energy, feelings of worthlessness or guilt, fixating on past failures or blaming yourself when things aren't going right, trouble thinking, concentrating, making decisions and remembering things, frequent thoughts of death, dying, or suicide, crying spells for no apparent reason, and unexplained physical problems, such as back pain or headaches. Some of the risk factors for depression include, first of all, just being a woman, having a biological relative with depression, having had a traumatic experience as a child, having family members or friends who have been depressed, experiencing stressful life situations, good or bad, such as death of a loved one, a move, losing your job, or even happy ones such as a promotion or someone getting married, having few friends or other personal relationships, recently having given birth, although a very joyous occasion, the change in hormones can cause postpartum depression, having been depressed previously, having a serious illness such as cancer, diabetes, and heart disease, Alzheimer's or AIDS, and having certain personality traits such as having low self-esteem and being overly dependent, self-critical, or pessimistic, abusing alcohol, nicotine, or illicit drugs, and taking certain high blood pressure medications, sleeping pills, or other medications. And that concludes my portion of today's of this presentation. Are there any questions? Okay. No questions right now. If one comes to your mind, or if you're still waiting for your next cup of coffee, I'll be around, so I'll be glad to answer any questions. And the next segment of our program will discuss in more detail the symptoms of these diseases and some of the assessment tools that we have available to us. Thank you so much, and have a great day.